Hello, everybody. Thank you for coming. I'm very happy to stay here in this beautiful and historic city. Before starting my presentation, I would like to immediately thank European Society of Sleep Technologists for this second opportunity. The first was in Rome a few months ago on the occasion of the World Sleep Congress. I think a great experience for me and for my Italian colleagues, on whose behalf I send you my warmest regards. Good. I would also like to thank Prof. Renderat, who on this occasion saves me a part of my presentation by speaking of OSAS phenotype in his splendid presentation. Thank you. I will therefore tell you about emerging treatments of OSA, and I will do so by analyzing a lot of scientific papers, highlighting above all those studies that compare the pros and cons of the use of associated methods. So, what we know, OSA is a syndrome characterized by the obstruction of the upper airways, where the following structures are involved: nose, tongue, soft palate, walls of the pharynx, mandibular and maxillary bones. We also know that can find an OSA syndrome in all three of these cases. Some basis is predictive value, but different variants should be considered. Some of these concern craniofacial dysmorphism, such as temporomandibular joint trauma, retrorhizia, and other craniofacial structural defects. The presence of a large neck with the presence of adipose tissue of thyroid problems. Okay. Another consideration to make is to define the nature of the apneas. In this case, central apnea led to a completely different approach than obstructive. This is the image of Arnold-Chiari syndrome is an example. Let's go to specific. In this study highlights in detail the new methods of therapeutic management of OSAS, however specifying the importance of a specific classification for each individual patient. That Randall spoke very well about this. We can therefore enclose in this graph the fundamental principle of approach of OSA patient. There are the current consideration, the heterogeneity of obstructive sleep apnea. We know the patient commonly presents with breathing disorders during sleep associated with the upper airway obstruction. However, the various OSA phenotypes can be different based on the clinical symptoms, polysomnographic findings, underlying pathophysiology, measurable biomarkers, anthropometric parameters, comorbidities, and outcome. So, what we can do for OSAS, CPAP, BPAP, mandibular advanced devices, myofunctional therapy, positional therapy, hypoglossal nerve stimulation, surgery, otorhinolaryngomediatric or bariatric, and new perspective. This is what we expect to restore in patients with sleep disorders. I am a neurophysiologist, and so the age is like milk to a baby. Therefore, the consideration that we must have in the therapeutic action is precisely that of restoring a correct sleep-wake rhythm, which, as we know, is the basis of many of the complications to which our patients exposed. Polysomnography and monitoring cardiorespiratory is a gold standard for the diagnosis, we know, and I hope, no, I'm sure that you know this pattern for a complete polysomnography we can view the AG, the sleep stage. This is a pattern of obstructive sleep apnea, and this is a pattern of mixed apnea, central apnea, child stocks, and this is the cardiorespiratory monitoring with video that we do to the patients with the residual OSAS in treatment of CPAP or residual daytime sleepiness. Okay, now we can go to speak about therapy for OSAS. As I told you, there are many studies that demonstrate the effectiveness of this therapeutic method. It is, in fact, a device that determines mandibular advancement by pushing the tongue base anteriorly, preventing collapse in the pharynx. The caution required consists in gradually modifying the stage of advanced to avoid trauma to the temporomandibular joint. It is clear that each study highlights a common factor. This method is not standardized and is applicable only to a certain type of patients with common characteristics. OSAS mild and moderate without obesity and with an acceptable dental situation, of course. In the analysis of the bibliography, I noted the presence of some studies demonstrating the efficacy of combined med and CPAP therapy and how this association improves compliance, adherence, and reduces residual HI. Myofunctional therapy has recently been demonstrating an efficacy compatible to that of other therapeutic methods. However, even in this case, the type of patients who can access this therapy must have some characteristics such as initial and medium forms of apnea without obesity and without craniofacial problems. Each of the selected studies concludes that CPAP remains the only non-invasive approach for severe forms. In conclusion, myofunctional therapy can be useful intervention even among middle-aged to elderly with OSA, increased tongue pressure, and may have contributed to the AHI improvement. So, hypoglossal nerve stimulation is an emerging method which consists in implanting a pacemaker on the patient, which determines the activation of the hyoid muscle through the hypoglossal nerve, capable of generating the contraction and consequently the downward movement of the tongue base filling up the space in the pharynx. The practical effectiveness is not discussed. What one wonders is the opportunity of a method that is in any case invasive. Furthermore, there is not much scientific evidence that can demonstrate a correct sleep pattern. I mean, how much can the production of electrical stimulus determine an arousal and contribute to a fragmentation of sleep? In my opinion, further investigations of the case are necessary. A new perspective consists in naturally reproducing a downward displacement of the tongue base through the hyoid bone by means of respiratory therapy, which determines alternately with the stimulation of the cervical loop, a synergistic effect capable of restoring an adequate respiratory space. However, even in this case, the type of access to this method must include some characteristics. The goal is to obtain the same result as a pulsar nerve stimulation by working on the respiratory muscle and consequently increasing the expansion. This allows to push the hyoid bone caudally and consequently limit the tendency to collapse of the tongue base in the pharynx. Positional therapy is now a standardized and effective method in all those cases in which OSA is poorly positional. We know that the supine position predisposes the collapse of the soft tissue, which generates apnea, and as a method, it is applicable in most of cases. The association between CPAP and positional therapy in some cases can determine the improvement of adherence and reduce the residual AHI index. I don't want to talk much about otolaryngomatoid surgery because there would be a lot to say, but there isn't much time available. Sorry, it must be said that the method of OSAS is considered the last chance when all else has failed. Many studies in the literature show that many operated patients do not solve the problem and sometimes make it worse. However, if we mean surgery that aims to solve minor problems that allow us to improve adherence to CPAP treatment, in this case, the use of minor surgery has its value. How many patients do not adherence to ventilatory treatment due to problems such as turbinate hypertrophy, nasal septum deviation, and other minor problems that can be easily managed surgically? In my view, many, if not most of them, hence the importance of consulting an otolaryngologist to evaluate the anatomical and functional conditions of the main organ responsible of breathing. Additional study is necessary to determine if CPAP adherence improved as a result of the lower CPAP or due to the fact that surgery was tried and was not completely successfully. I would also spend a few words to define the role of the diagnostic method that has the possibility of selectively framing patients who can access surgery and those who are not advisable. Drug-induced sleep endoscopy has precisely this purpose. That is, to try to identify the seat most responsible of the obstruction. I don't want to speak about maxillomandibular surgery because there is no time, but there is extreme solution, and the OSAS is not only the problem. I go to define the conclusion of my presentation, speaking about the results of the study. Only mandibular advanced devices improves the AHI index in normal weight patients with mandibular retrognathia in initial and middle OSAS. CPAP and MAD improved CPAP adherence and in some cases decrease AHI index in severe OSA in patients without obesity. Only myofunctional therapy decreases AHI index in initial and middle OSAS without obesity. Myofunctional therapy and CPAP combined do not determine significant combined results. only for improve adherence of treatment. This is, sorry, it's a repetition. Positional therapy decrease the AHI index in all grade of OSAS without obesity, but in several cases can determine sleep fragmentation. Hypoglossal nerve stimulation can be a good solution in all cases, but we don't have a lot of information about the impact in sleep architecture. Some patients don't improve the excessive sleep daytime. Otorhinolaryngology surgery isn't the first solution, in the most of cases, but can be complementary for a good adherence and compliance in CPAP therapy in many cases. Facial maxillosurgery is an extremely solution in case of craniofacial dysmorphism and other comorbidities. Bariatric surgery decrease AHI index in all grade of OSAS in obesity, but in some cases CPAP therapy must be continued in post-operatory time. In conclusion, CPAP therapy is the gold standard for OSA treatment, but we have a necessity in a good polysomnographic diagnosis. We must evaluate several parameters: evaluation of anatomical variance, evaluate daytime symptoms, optimal titration, good interface choice, a fundamental follow-up to middle and long term. In conclusion, I would like to conclude my report with this video, which has nothing to do with OSAS. However, this patient comes to my laboratory after several diagnoses of mild OSAS, AHI 7 per hour, reporting excessive unbearable daytime sleepiness. And the first night in the structure, I only turned on the camera, and this is the result. It's objectively an REM behavior disorder. This is to say that we need to pay close attention to the diagnosis before establishing a correct treatment, which in this case is totally different from what we have to say so far. Thank you so much.